Good morning. It's quite an honor to be with you. The comments this morning already have been enlightening, particularly around how common our experiences are, our realization of what needs to change in medical education and health professions education. And I'm delighted to have a chance to share with you the way we have approached this as part of our work in the AMA initiative and at East Carolina University. This morning, Susan, you started by saying that we're thinking about preparing health profession students for a health system that's no longer there, and we don't know what it's going to look like. And so as we approach this, we're certainly cognizant of the fact, as all of you are, of this notion that we have to prepare a workforce for a very different healthcare delivery system. One of our students said to me a couple years ago, you know, you think about the time we spend in medical school. If you look at our curriculum, how much time we spend on the cardiac system, how much time we spend on the pulmonary system, the renal system, the GI system. But you're not teaching us about the system that we're going to be working in every day as healthcare professionals. When do we get to learn about that system? And so that was really, I think, a call to not wait any longer, not wait till somebody else figured this out and then we would adopt it, but to really move forward. This is not any new information to any of you in terms of the changes that we're experiencing in healthcare, but we do know that we're deficient and we haven't kept pace in implementing what I'm referred to as the new competencies: patient safety, quality improvement, team-based care, population health, system science, into our curriculum. And that really was our goal as we were going forward. As we had this opportunity to work with the AMA, we were thinking about what we would entitle our program. So I'm going to talk to you about something called REACH, Redesigning Education to Accelerate Change in Healthcare. As we thought about how you go about doing this, we were challenged by the AMA to think about radical, fundamental, dramatic changes in healthcare. As Susan said earlier, don't tweak around the edges. We're not interested in you working with us if you're going to tweak around the edges. So in thinking about what those components were, our approach were three things, and I'm going to mention first the longitudinal curriculum and the LINK program. With our longitudinal curriculum, we didn't feel like we were at a place in our institution where we could just throw away everything that we had, create this big bang kind of phenomenon, and we also we purposely didn't want to create this curriculum that was over here, that was the curriculum in patient safety and quality. Because our students, if we create those siloed sort of curricula, will say, okay, well, you know, I've got to study biochemistry today, and then I know I've got this class in quality and safety next week, and I got to read something before I go in there. So we started out with a purposeful intention of finding ways to vertically integrate throughout the entire 4 years of medical school in ways that we refer to as stealth. It's just the way you learn to do things. It's not this thing that we're setting out here as something that's different. We also felt like that we would have a group of students who really were the kind that prompted me about where are you teaching us about the healthcare system, who wanted to go on and do more. So a separate track of students who wanted to get really advanced training in these competencies and really to get additional leadership training, become leaders in this. Then we realized that the real sticking point, the real challenge to getting all this started, and this is also something Susan alluded to this morning, is this entire generation of faculty that we are part of, didn't grow up in this system, and we weren't trained along those lines. And so when we set out, we said we're not going to start with the curriculum. We know we have 5 years working with this initiative with the AMA to change our curriculum. And for the first year, we're not even going to talk about what that curriculum change is going to look like. We're going to start with the faculty. Very different from how we've usually done it. We usually say, if we're going to do curriculum change, we're going to get this little group of education people over here, and we're going to design what it's going to look like. And then we're going to go out and find the faculty to teach in it and tell them how we want them to do it. So what if we flipped that and said, let's bring faculty together and intentionally get people who aren't the normal education core that design the curriculum. Let's get people who are out there working in the environment. If you think back to that earlier slide about the changes in the healthcare system, we could create a curriculum and teach about this, but what people experience, what our students, what our learners experience every day in the healthcare environment is what they leave with. So if we weren't training the the non-traditional education people, the clinical faculty working every day in the environment, in a way that changed that clinical environment. It didn't really matter what we created in curriculum. So this really was the challenge, is the very people we wanted to help us are trying to work in this environment every day. They're trying to figure out why it's and how it's changing themselves. And they also want to be competent in their teaching, so we're asking them to teach something that they don't know. So you put all those together, and I think it's a particular challenge. We went at it in a sort of a twofold way. First, we can't talk to you about, we can't work with you or have you work with us around curriculum development for competencies that you yourself don't have. So this 15 months of the Teachers of Quality Academy was designed to have really fully the first 2/3 of it around learning the content. We used IHI's Breakthrough Series collaborative model, a series of learning sessions with work that they would do in between. So you can see there they started with pre-work and online modules and some cognitive preloading, and then had 6 different learning sessions that were 2 days each, where they came, this group of faculty, we graduated 28 last night. Last night was our graduation before I came here. We had wanted to get 20 people. We had to cut off applications at 39, and then we did have some attrition early on from people who didn't quite realize what they were getting into, but we kept a core of 28 throughout this process. And they worked in small groups, and what they had to do was learn the competencies, but they had to apply it in their healthcare system, wherever they were working. We had faculty who were obviously from medicine, but when we started this, we said, you know, if interprofessionalism is one of the new competencies, if we're only training clinical MD faculty to do this, that's kind of contradictory to what we want to do. So we opened the program to faculty from our College of Nursing, from public health, from our allied health programs, and they participated with us. So our teams faculty were interprofessional. We also had a no department left behind, so we had somebody from each clinical department, because we wanted this to be something, again, stealth, that changes were occurring through each of our clinical disciplines. And they worked in teams, and they started January of last year working on developing their own healthcare quality improvement project and peer teaching and being coached through that by the members of our project team, and went through this curriculum. About 2/3 of the way through, our College of Education colleagues from the university came in with us, and they created a 3-course credential, graduate course credential, just for this group on, now that you have this knowledge, you aren't people who normally design curriculum. How would you go about thinking about curriculum? How would you design it? How would you evaluate what the outcomes are? And they did this predominantly as an online distance ed program, and it involved our faculty submitting discussion board, reading, things like reading about the new and trustable professional activities and how would you apply that in medical education. I will tell you that it was fascinating to see the barriers break down. We had not necessarily had faculty who spent a long time outside of a clinical setting, even working across our own medical disciplines, much less across health profession schools. And they got in these discussion boards, and they got in their small groups, and they started challenging each other and sharing ideas. One of the medical faculty said, we do a terrible job of teaching about handoffs. And one of the nursing faculty said, you know, we really got that covered well, we think, in nursing. Let's tell you about it. And the medical faculty said, wow, we've got a lot to learn from nursing educators. And that might sound simple and something that should just be the way it is to this group of folks, but it doesn't happen that way every day on the ground. And so this was the design of it. So the interprofessional faculty training was there. We also started with a strong sponsorship model. We said, if you want to participate, you can apply, but you also must be sponsored. Your chair, your dean, whoever you report to, has to also nominate you. We want to make sure that you have the support that you're going to need. I was able to shift a bit of state funds that we could sponsor some faculty time. It was a 0.1 or FTE or 10% of their time, and they didn't all even get that time. They were busy clinicians and educators, but we did try to provide some time for them to do that. I've already mentioned about learning the competencies by doing them. And then really it was this goal of expanding this faculty who could contribute to what we were doing. So what have we found 15 months in? The faculty who graduated last night, these 28, had just tremendous competing priorities, but they stayed really committed to this, and they developed their own their own cohort culture, and they really felt pride in this program. I have to tell you, at the January a year ago when we did the kickoff banquet, we had our health system leaders there as well, not just our academic leaders, so that they felt that sponsorship from them. And I said to them as we were finishing at the banquet, I said, now all of you who are sponsors, are you ready tomorrow for this then 39 faculty to start working throughout our healthcare system changing things? And they had to think about it, but the changes have been, the clinical changes were the first, and they were very dramatic changes. We had changes, readmission rates that dropped. We had improvement in radiation exposure. We had handoff, improvement in handoffs both within the healthcare system and between the acute care system and the outpatient system. We just had, there were 28 completed quality improvement efforts that continue to this day. The interprofessionalism and the systemness is really palpable around our campus. They are leading these clinical improvement efforts. They've completed the credential in health professions education, and they marvel at the fact that they did it. They've never thought of themselves as educators. A surgical oncologist who really is a almost full-time clinician is using words like flipped classroom. So this was pretty exciting. And we now have new curricular products. The idea was this new longitudinal curriculum will come from what this group creates. And I would dare say tell you that yesterday when we heard 15 podium presentations and had 25 poster presentations from faculty who had been working on the educational side of this, now how do we turn this into education? It was far beyond what our small group of traditional education curriculum design people would have done. They've also developed partnerships. As they were reaching out to learn about these competencies and to do their work, they were developing partnerships that went beyond. But the most exciting thing really was the unanticipated outcomes. So remember, we just started this in January of 2014, and we just graduated this group last night. And they didn't wait till they finished the program. They got so excited. They put their improvement goggles on. They saw what it meant to change the system, and they didn't wait till we were developing this medical school curriculum. 10 of them went on to develop new educational programs while they were in their training for their residents, for their nursing students, and their allied health students. It's actually now 8 as of this week, so I sent these slides in a week ago. 8 of them have gone on and spread their work, or have been accepted to spread their work at national meetings to tell the story of what they learned and what they did in clinical or educational improvement. As the year went on, we saw them less reliant on us as their coaches and more reliant on each other as peer teachers. So we think the sustainability of this is really going to be good because they are supporting each other. We've had 2 assume major leadership roles in our health system around quality and safety and transforming care. And then we had other health science schools who watched this and said, wait a minute, we didn't participate the first time around. When are you going to do this again? That wasn't really in the plans, but we're now looking at that, and they want to continue to do that. So just in terms of lessons learned, it is hard to teach while practice while learning. And it takes thinking about what our faculty are up against and meeting them where they are, and then helping them understand the contribution that they can make. We did learn a lot about cohort selection. We did have some attrition from this program because it was new. We really were putting the pieces on the plane as we were flying, and so we weren't as clear. We will now know how to better select people for the next cohort. It did take a lot of hands-on mentoring, and that turned out to be a particular design feature of importance. The asynchronous platform helped both for their time, but also helped break down some interprofessional barriers. They were first more willing to talk to each other in a Blackboard format and then the next time they were together, they felt more at ease in talking to each other. And then the interprofessional faculty piece has just been phenomenal. These faculty have gone on already before it finished. We've already had 2 years where we've had medical and nursing students do team steps training together. In January of this year, we had our first QI Olympics. We had students from the College of Nursing, the College of Medicine, and also from our local community college, and the 2-year nursing program joined. So going forward, we have work to do. Our Link Scholars have been selected for the first cohort, and we'll start this summer. And we are working on embedding all those components that they developed in a meaningful way in this longitudinal clerkship. So now we can really start the the process of curriculum development and implementation. So thank you.